Thank you very much for that introduction. In fact, I have many times quoted Dr. Etsten's references in various articles that I've written, so I do feel very pleased and privileged to be delivering this lecture in memory of him. The theme of my presentation will be pain relief, a basic human right. And I'm going to start, I'll be craning my neck around a little bit, I'm afraid. Perhaps I'll come a bit further forward towards you. That might work better. It'll be a bit more intimate anyway. Well, that's a much better idea. It's interesting to look at the possible versus the current situation. Wrong end, there we are. And there's no doubt now that in the case of post-surgery and trauma pain, in other words, the acute pain area, and in cancer pain, that we now have the possibility of relieving the large majority of this pain. The reality, however, is a bit less than that, and I suspect that throughout the world, certainly in my country, that the figure probably sits around 50%, and we see that in various reports that keep appearing. And that's a shame, because there still remains this gap between the possible and the reality. In chronic non-cancer pain, when I got into this area by mistake 30 years ago, I would say that the possibility of relief was actually about 10%. Virtually nobody with chronic pain was getting any help of any sort of meaningful type. Whereas today, it is quite extraordinary that we can actually help about 75% of patients with chronic pain. Yet the reality still is that less than 10% are getting access to this help. So this is an extraordinary situation, and I think it's obviously a medical issue, but it's also a societal issue. Now, I'm sure you're all aware of the human costs of unrelieved pain. Erosion of lifestyle, mental and physical deterioration, loss of job, professional, community standing, weakening of relationships, disruption of families, even financial ruin. We frequently see this. And this terrible sense of helplessness and despair. This is really a horrible situation for any human being. We are starting to put together data for the first time in Australia. When I was president of the Australian Pain Society, we commissioned a health economist to do what I'll call a very rubbery study of health costs associated with pain in Australia. And we came up with a figure of about $15 billion annually, which for a population of only 18 million is a fairly sizable cost. The interesting thing, however, is that if you look at all the data in the world now, the costs are rising exponentially. This is particularly so for back pain. 70 million lost work days, we estimated. Of course, inappropriate drug prescriptions, abuse and toxicity, huge costs associated with this. Panadine Forte, which is Tylenol plus codeine, is the second on the list of expensive drugs in Australia. Very, very massive costs. We still have a high incidence of inappropriate surgery with multiple complications. Bit of a synaptic delay in the machine here. Big synaptic delay. Now, we're trying to put this into hard data now. We have a small epidemiology group which is really gathering the first prospective epidemiologic data on pain in Australia. I'll just give you a little snippet of this. This is from the work of Dr. Fiona Blythe, who is a medically qualified PhD candidate. And this is a degree of interference with daily activities. These are people with persistent pain. So this is gained from a sample of the New South Wales population, the state in which I live. And you have percentage of males and percentage of females, and you have the actual numbers down the side here. Perhaps for convenience, just focus on these two lower items here. So here are patients with quite a lot of interference, 23.5%, and those with extreme interference, 10.8%. So over 30% of this sample of patients with pain had either a lot or extreme interference with activity. And this, of course, is what we've now come to focus on in patients with pain. When I started in this area, we were looking at pain only. We weren't looking at what pain was doing to the individual, which is quite extraordinary, really. Now, this is a very, very condensed summary of what we found so far. It is, in fact, the first Australian population survey to establish the prevalence of chronic pain. Overall, 17.1% of males and 20.1% of females reported having chronic pain. I found this quite a staggering figure, quite extraordinary. And the majority, about 2/3 of these, reported interference with daily activities due to pain. So that's 12.3% of the New South Wales population. Now, I would hope that that'll start to interest our politicians and our general community in this as a major public health issue. So I and many others have proposed that chronic pain will be the disease of the 21st century. And I think it's very likely, sadly, that that prediction will come true. Fortunately, our Federal Health Minister, Dr. Michael Wooldridge, who just got re-elected with the government, so there's some hope that we'll be able to push this on a bit, has taken a real interest in this. And in one of his major speeches last year, he said the major costs in healthcare in Australia are what he called common diseases: pain, asthma and diabetes. And he said that savings in best practice could result in about 25% savings. Well, we actually think it's quite a bit bigger than that. Best practice could make at least 50% savings, but we'll settle for 25%, which will mean a very, very large dollar cost in savings. Could be about $4.8 billion annually, taking his figure of 25%. That should fund a few good NIH-type grants, I would think. I think you can also regard chronic pain as being the silent epidemic. The dollar costs exceed the costs of AIDS, cancer and heart disease combined. That's a pretty impressive statistic. Patients with chronic pain do in fact often suffer silently for many reasons. Patients with back pain get sick of the attitudes that are taken to them, and they learn very quickly that it's a good idea to shut up about the back pain because you're not going to get a very favourable response. Relatives and others are silent and they hope it won't happen to them. So they'd rather not think in terms of having low back pain that interferes with their lifestyle. Gee, I hope I don't get back pain. God, you know the connotation of that, having back pain. Society is silent because it's largely unaware of the human and financial costs. I think politicians are silent because the costs are really so overwhelming. They say, oh, another one of these big expensive areas. Those figures are probably rubbery. Let's not get into that. And there is sadly currently a huge gap between existing knowledge and practice. And in one way, on a positive sense, that gap is widening at a rapid pace because this is one of the exciting areas of the neurosciences. There's no doubt about it. It's a good time to be in pain neuroscience. It's really a very, very exciting area. But it poses a big problem. Now, we've had a great deal of political and community interest in Australia recently, and you may have read some of it in your newspapers, because I think we were one of the first, if not the first country in the world, apart from Holland, to actually look at passing legislation to make euthanasia legal. And this was in the northern part of Australia, the Northern Territory, which is a bit of a frontier sort of, it's not a state yet, it's a territory, so it's a bit of a frontier area. And we had an individual up there who I suppose, a bit like Dr. Kevorkian, decided that he was going to really be the pioneer of euthanasia. Unfortunately, the debate tended to focus only on those with incurable cancer or other incurable conditions right at the end of life, who decided that they didn't want to continue. However, it ignored the fact that there are very large numbers of patients with severe non-cancer pain who suffer enormously and will have to suffer, in fact, for a lifetime of unrelenting, excruciating pain. And you can take patients, for example, who've had an amputation as a result of road trauma at age 30 and have severe neuropathic pain associated with that. The potential is that that individual will have that pain for the rest of his or her life. And these are not small numbers of patients. These are very large numbers of patients. Many of these patients contemplate suicide, and there's no doubt whatsoever that they would seek euthanasia if legislation was available. Every week I have a patient coming into my clinic saying, if you can't do something, I really don't want to go on, and I'm not going to go on. And they're serious, there's no doubt about that. But we know now that pain relief and associated symptom control does indeed restore the will to live. In my 30 years of involvement in pain medicine, I've only seen a handful of patients who, if their symptom control was adequate, really still wanted to die. It's very, very unusual. So I think relief of chronic pain should be the priority in the euthanasia debate, and yet it really hasn't surfaced at all. Now, I think probably most of the audience do have some connection with this area, but for those who don't, I'd perhaps ask you to just try to crawl into the skin of a patient with chronic ongoing pain for a minute. And this is a poem written by a psychologist, Leshan. Terrible things being done, worse threatened. Outside forces in control, will is helpless. No time limit set, cannot predict when it will end. Pain is alien and meaningless. Consciousness turned inward, time perspective lost, relationships weakened. Well, I wonder what that image conjures up for you. Torture? I think so. And is the situation where a health professional has the knowledge and the expertise to relieve pain in a patient and fails to do so, is that torture by omission? Now, that's a very interesting concept. It's one that I've discussed with Margaret Somerville, who some of you will have heard speak, is a professor of law at McGill University and has taken a great interest in these issues of euthanasia, human rights, etc. And she believes that that's actually an adequate description. And you'll be aware now that there have been some legal cases where healthcare professionals have been sued for failing to provide adequate pain control for patients. This is actually an illustration which depicts a patient with areas of neuropathic pain. And neuropathic pain, of course, is among the most severe pain states. There are many different types of neuropathic or nerve damage pain. And this depicts a patient with the shaded areas here indicate the areas where this individual has neuropathic pain. Imagine what it's like having all of those areas involved day after day, night after night. I've developed a new system. This is a description. Neuropathic pain is poorly diagnosed still, particularly in certain settings. For example, in the perioperative setting. Until recently, it wasn't really well recognised that there was a possibility of early onset neuropathic pain. Still not diagnosed very well in the cancer population and in others. And it's not a difficult diagnosis to make clinically. Often, of course, there's pain without any obvious tissue damage. Very frequently, there's a poor response to opiates, which should be immediately a bit of a red flag that something different is going on here. There may, of course, be neural damage. For example, a patient with spinal cord injury, as you'll see shortly, is at high risk of having neuropathic pain. The pain character tends to be a bit different, often described as burning, and there may be paroxysms of pain, no pain at all, and then severe pain. There may be allodynia, in other words, if you touch the skin, you may generate pain, and that's a very terrible experience for any person to have. There may be hyperalgesia or an increased response to a noxious stimulus. This is very helpful. There may be dysesthesias, very unusual, unpleasant sensations. We have found, and this really warrants a formal study, that patients don't spontaneously report dysesthesias. They don't feel comfortable about telling you that they feel as though there are ants walking over their skin. Sometimes they feel that suddenly there's a breeze blowing across their leg. One patient described to me that he felt as though there was boiling oil being poured into an open wound on his body. What a terrible sensation to have. You can, of course, tap a neuroma and then get a spray of electric shocks into an adjacent area. And finally, there's this condition of hyperpathia. If you keep stimulating the painful area, the response gets greater and greater. And after you stop stimulating, it stays up there for quite a long time afterwards. So these are all things that can be done clinically to diagnose neuropathic pain. And it remains an area that currently is underdiagnosed. Now, I've just given you that as an example of a very severe pain problem. I'd like to turn to a slightly different aspect of the theme now. And this came to me really from a former, very eminent anesthesiologist, Professor Manny Papa, who at the age of 70 plus embarked upon a PhD in the School of Fine Arts at the University of Miami. And the title of his thesis was Anesthesia, Pain and Suffering and the Romantic Era. And this is a small quotation from his thesis. Attention to individuality by the Romantic poets, essayists and philosophers was crucial to preparing the way for a change in clinical medicine designed to relieve pain and suffering and to prevent it where possible. And this only occurred because of the production of an environment in which anesthesia could be accepted. Now, I think that's a very interesting concept, as we'll see shortly, that can be applied to our current situation with attitudes and practices in chronic pain. Now, just very recently in 1997, the sesquicentenary of the first use of chloroform for analgesia in childbirth was held in Edinburgh. And of course, this was just a year after an important event here in Boston relating to the use of ether for anesthesia. And it's interesting that these two events came very close together just towards the end of the Romantic era. And I think a very good case can be made that the acceptance of these two events was partly influenced by societal attitudes. Now, for example, you will be aware that there was a lot of skepticism about the introduction of anesthesia, which was not helped by the unsuccessful demonstration with nitrous oxide. And one can well imagine how that poor individual felt after being booed out of the room and castigated for doing something so dangerous as having the temerity to render somebody unconscious. Interestingly enough, the same thing happened with chloroform. Queen Victoria had chloroform analgesia for the birth of Prince Leopold, and she did so against enormous opposition from the church, from leading figures of the day such as Professor Syme, the professor of surgery. And this was so extreme that an article appeared in The Lancet commenting on this event, which said, "You may have heard that Queen Victoria had chloroform analgesia for the birth of Prince Leopold, but in fact this didn't happen." And then went on to describe what an irresponsible thing this would be, to give chloroform for a natural process such as childbirth, and particularly in the sovereign, to exhibit this enormous risk. So the article actually said she didn't have it. Everything's back to normal. Don't worry, this didn't happen. And that, I think, illustrates the enormous opposition that had existed up until this time to what really were two important humanitarian events that occurred. Now, another very influential anesthesiologist was Emery Rovenstein, and I was privileged to give the Rovenstein lecture at the American Society of Anesthesiologists meeting last year. Rovenstein, incidentally, was credited with one of the first uses of nerve block for the treatment of pain, in this case suprascapular block for shoulder pain. And it's rather interesting how coincidences occur. He was teamed up in 1948 with Papa, and they wrote a number of papers, and in one of them they said, "Events in the changing medical world have made it imperative that we accept the challenge of pain occurring outside the surgical amphitheatre. Such a concept fully justifies an anaesthesia clinic on the therapy of pain." Well, that was in 1948. We are moving, but perhaps we're not moving quite as fast as they had anticipated. Now, this man, who I suppose I regard as my godfather, and that's probably an appropriate term in the field of pain medicine. I met him shortly after I arrived at McGill in 1969, and there's no doubt that John J. Bonica single-handedly attempted to push these concepts onwards, to make pain relief available, to apply appropriate team approach to pain medicine, and really devoted his life to pioneering this approach. I think, however, we are still at the stage where we have not yet harnessed societal and political interest in the importance, both humanitarian importance and financial importance of really attacking pain relief as a human right. And I think we're now probably still in the mid-1800s in terms of taking this forward for patients with chronic non-cancer pain in particular, and to some extent patients with cancer pain. So I think patients with severe chronic pain represent certainly a massive medical, also economic, but most importantly a societal problem. How can our society, if they really have knowledge of this problem, allow it to continue at the current level? The patient's perspective is that they'd be better off with cancer. And many patients say to me, well, at least if I had cancer, people would be able to acknowledge that I had a clear basis for my problem, which everybody understood and acknowledged, and then I'd be much better off. I'd feel better about it. So I think really there currently is a lack of a societal humanitarian approach. And this is akin to the lack of acceptance of childbirth pain circa 1847. And when you think of that incredibly brave move that Queen Victoria took, it was incredibly brave. She opposed the church leaders, the medical leaders, societal opinion, and she said, damn it, you can all go to hell, I'm going to have analgesia for this childbirth. That was a very, very major move. And I think we need a similar major societal move at the moment for patients with chronic non-cancer pain. There really is a lack of government focus on the huge economic cost, and I have to say that there are pitiful clinical resources. There are now so-called pain clinics. Some of them are just that. One clinician, a shingle on a door, maybe somebody else helping. They are not what the ISP has defined as multidisciplinary pain centres. Such as there are around the world, many of them are struggling and some of them are failing. In my country, we only have a handful of centres that would qualify as being a major multidisciplinary pain centre. So I think we aren't exactly moving ahead at a rapid pace. Until recently, there was no discrete specialty status, and that, of course, is a major drawback. However, I think there are some very promising signs. Through the University of Sydney, for the last 3 years, we have been running a diploma and a master's degree in pain management. It's a postgraduate degree for students from all disciplines, so not just restricted to medical practitioners. We teach in a multidisciplinary setting. Nurses, physical therapists, clinical psychologists, medical practitioners. A very interesting challenge to do that. It's an evidence-based approach, and next year in March this will go to the World Wide Web, and there will be a distance program in 1999 for the diploma course, not for the masters. So that's one initiative. Another very interesting one came to fruition only a week before I left Australia. There is now in existence in Australia a faculty of pain medicine within the Australian and New Zealand College of Anaesthetists, which, if you will, is acting as a home for this faculty. The board of the faculty, however, is comprised of representatives from this college and also from the Royal Australian College of Surgeons, physicians, psychiatrists, and the Faculty of Rehabilitation Medicine. In other words, we've got together and we've decided that we are going to run a single specialty qualification, and that's it there. It looks like alphabet salad, I know, but it's a Fellow of the Faculty of Pain Medicine in Anscombe. There'll be only one training program and only one examination. The Foundation Fellows will be inducted in March of next year and the first examination in November. And we will, of course, be approving training centres and programs. So I think this is a very encouraging sign. So we will now have an identifiable specialist body of people. Incidentally, no one will be able to achieve this degree without first achieving the degree in their primary specialty. So psychiatrists will not be gaining this degree in doing nerve blocks and implanting pumps, for example. Now, I want to turn to my main theme with that background. If one looks at the broad field of human rights, and Dan Carr has made me aware this morning of a very interesting article in The Economist that takes a broad-ranging look at this. It really goes back a long, long way. The Bill of Rights in the United Kingdom started in 1689. In the US Constitution and its amendments, there are indeed phrases that have to do with important human rights. And of course, in France, the concept of liberty, equality, and fraternity. This, in fact, has its precedence in the Magna Carta in 1215. One can clearly trace the concepts in the Magna Carta to this document. Probably the most important, however, of course, is the UN Declaration of Human Rights, dating to 1948. You can now download this from the internet. It's very interesting to see what it says. One of the important things it says is all persons are equal in dignity and rights and have the right to life, liberty and security. And it goes on in other clauses to describe things which indicate that one should have access to good medical care, etc. And by implication, I guess that means that maybe you might have good pain relief too. But it never spells it out. It never makes, there is not a single mention of pain relief. And yet, of course, if one considers the history of medicine, pain relief was right at the top of the priorities for the physician. In Article 7 in the UN Declaration of Human Rights, it says, "No one shall be subjected to torture or to cruel, inhuman or degrading treatment or punishment." Well, that's getting pretty close to it. I would have to say, and it's a pity to have to say this, but it is true, that in certain settings of clinical practice, I still see patients who come pretty close to that phrase there. And what I would like to see in the UN Declaration of Human Rights is a very specific statement about the importance of pain relief. Now, if you just think for a moment, what would be your list of basic human rights and how would you prioritize them? Well, let's leave this one for a minute. But if you look at the Declaration of Human Rights, freedom from hunger and thirst, they're in there. Peace without political or other persecution. Freedom of speech, press, religion, assembly, mobility, and unpolluted food and water and air supply. They're all actually in there. And I think they're all things, when I sat down to think about this, they all came right up high on my list. It's a bit hard to know which one to put at the top. But when I compared relief of severe unrelenting pain, I had to say it rated there in at least the first three. And most people I've talked to have agreed with me. How can you enjoy some of these other human rights if you are suffering from unrelenting pain? It then becomes your focus. And any of you who have experienced pain that's gone on for more than a week and has been severe will know that you're not interested in anything else. You don't care what you eat. You don't care what you do. There's only one focus you have, and that is getting some relief for that pain. So this must rate somewhere on this list of human rights. Now, there have been a lot of national government reports on pain and its treatment, and I've now participated in two of them. The first one by our equivalent of your NIH, which is called the National Health and Medical Research Council of Australia, and it published a report in 1998 entitled Management of Severe Pain. And in that report, it made this statement: changes are called for in training, knowledge, attitudes and practices, that's a tough one, of medical, nursing and allied professionals, along with greater public awareness and expectations in the treatment of pain. I think that's a pretty good statement. Just about every word counts in that statement. That was in 1988. We finally got around in 1998 to publishing our first major document summarising the evidence on the management of acute pain as a start. So we have now a document that's just been passed by our council, which has been my job, the most difficult thing I've ever done, as Dan Carr well knows, because he's done two of them. A large committee, of course, a large consultative group, and getting everybody to agree on evaluation of scientific evidence and getting it into a document is quite a job. So we'll have, it won't actually be called a clinical practice guideline, it's going to be called Acute Pain Management, Scientific Evidence, and that's another story. We'll have a clinician's quick reference guide and we'll have a consumer's guide. We're using the Cochrane approach, levels of evidence ranging from a systematic review and meta-analysis down to the level 4 case reports, committee reports, and of course the old standard expert opinion, or opinion of esteemed experts. I'll just give you a couple of quick snippets. This is every statement in this document has a reference or references attached to it, and beside those references in the text there is a level notation. So as the reader goes through, they know what sort of level of evidence supports this statement. So here we have in acute musculoskeletal pain, treatment of acute lower back pain based upon bed rest and immobilisation is ineffective. Level 1 evidence. So don't do it anymore. Statement of evidence. A return to a normal range of activities as soon as possible leads to more rapid recovery from acute lower back pain than do either bed rest or back mobilising exercises. Level 2 evidence. So there's a couple of examples. So I think these are all very important moves that actually make it possible now to start saying we have a significant knowledge base that can be clearly identified. The level of confidence in that knowledge base can be identified, and this should be made available to people in a responsible and appropriate manner. Now, a slightly different angle of this theme is that chronic pain, in fact, is indeed not just a symptom but as a disease entity. And I think this starts to make the climate a bit easier to put this as a high priority. Pain has been very easy to fob off as just a symptom. After all, pain never killed anyone, did it? Well, I don't think so. But in fact, it does kill people. And there's very good evidence now that pain that continues is a disease entity. It certainly results in severe psychological changes and sometimes even psychiatric changes associated with unrelenting pain. But perhaps most importantly and most surprisingly is that there are persisting physical effects of chronic pain. And this is really surprising evidence accumulated over the last 10 years. There is indeed pathophysiology in the nervous system per se that's generated by persisting pain. And I won't be able to go into that today, but the evidence for this now is absolutely enormous that this does occur. Secondly, there is indeed reorganisation of the neurons in the dorsal horn, neuroanatomical reorganisation. I will give a brief example of this. There's also a lot of evidence of genetic changes in the dorsal horn, which actually increase the spinal responses. And finally, there's possible death of inhibitory neurons. And that's becoming more and more established now in association with neuropathy and neuropathic pain. Sadly, the neurons that die are indeed the ones that are inhibitory, and they seem to be of the GABA A type. And a lot of work is now going on to identify strategies and drugs that enhance GABA A activity to combat this loss. And that's looking extremely promising. The end result of all of this is physical and mental deactivation of an enormous degree. So this must be now properly regarded as being a disease entity. Now, this is taken from an ancient Aztec piece of work, and this individual has obviously got some nociception going on. But, you know, when we started thinking about pain, that's all we thought about. Clearly, there's a lot more than nociception going on for this individual. A lot more. And I think Cicely Saunders, who founded the hospice movement, provided us with a very important concept. She called it total pain. Really what she was saying is pain is a multi-dimensional problem. There are physical, psychological and environmental factors that operate. And that's depicted quite nicely here in this little summary. There's obviously the somatic source. There may be anxiety, fear of pain, of death, of hospital, of loss of control, anger at medical and admin failures, irritability, depression, loss of job, social and family role, insomnia effects, etc. This is clearly a multi-dimensional problem. Now, just to illustrate this, this is taken from some work. We have a large spinal injury unit in our hospital, and we've had a collaborative group working on spinal injury pain. And this is taken from the work of David Taylor, who incidentally was one of an Australian group who won the Nobel Peace Prize for their work on the Thai-Cambodian border He worked there for 14 years, repatriating people who'd been tortured, basically. So he applied his background to patients with spinal injury. And as with your experience with the SF-36, we found that some of the instruments were totally inappropriate for spinal injured patients. And there was a prevailing attitude that, well, if you have a spinal injury, of course you'll be depressed. There's no question about that. And that resulted from the use of scales such as the BDI, which are totally inappropriate for somebody who has no function from this level down. And what he found, as you can see here, looking at psychological strength, is that, to no surprise to him, these patients, in fact, on average, increase psychological strength in the days and weeks following spinal injury. It's a very important finding, because it means that you can then develop strategies to capitalize on that increase in psychological strength to help rehabilitate those individuals. Of course, there were some, in fact, who did not increase their psychological strength. But overall, there was this very impressive increase in psychological strength. Now, about to be published in the journal Pain is a longitudinal study that we did right from the emergency room level to well into the rehabilitation stage and beyond. And this study is still ongoing. And we wanted to really document with prospective data what is the incidence of different types of spinal injury pain. I'll just show you a little snippet of this. This is now an obsolete term, but this is how we gathered the data initially. We now just use the level, the terminology above level, at level or below level neuropathic pain. And below level neuropathic pain includes the old term visceral pain, because there's pretty good evidence now that so-called visceral pain in spinal injury patients is just a variant of neuropathic pain. So this is part of the population of patients who develop so-called radicular pain at the level of the injury. And you'll see that it's quite significant at 4 weeks, and at 2 years it tends to taper off a bit, but it's still running along at around 30%, around 20% or so. So a significant incidence of neuropathic pain. This is actually the group of patients who had below level neuropathic pain. And you'll see that there's actually a gradual increase, so that by 2 years you've got somewhere around 30% of the patients with this type of neuropathic pain. And if you add this to the previous one, this is a very significant problem in patients with spinal injury. Now, the prevailing dogma of some rehabilitationists who are treating these patients is don't worry about it too much because it always goes away. So just bear with it, and after a period of time it won't be there anymore. Now, this takes me finally to, I think, an illustration of why it really is appropriate to regard this as being a disease entity. This is a little blown up section of the dorsal horn of the spinal cord, which has laminae, and here are 5 of them shown. Here is a touch fibre coming in and synapsing deep, and these spidery looking fibres are A delta and C pain fibres, as you see, synapsing rather superficially. So these 2 fibre types are separated. We know now that in the presence of nerve injury, within just a few days, these touch fibres start to send out little sprouts, and they come back and they start to make junctions or synapses with neurons in this more superficial layer, which are the neurons associated with pain. And this, of course, now explains why some patients with neuropathic pain will get pain if you touch the skin or even move a hair on the face or blow on the face. This was established by Clifford Wolfe when he was at University College in London. Very surprising finding, but now duplicated in many laboratories throughout the world, including our own. And this is taken from Dr. Deborah White's work. This is a special staining technique. This is the dorsal horn area of the spinal cord, stained for A beta fibres, the touch fibres. Here they are coming into the spinal cord, and you'll see them synapsing rather deeply in the deeper layers. You'll notice that in the more superficial layer here, there aren't any synapses of these touch fibres. However, after 3 or 4 days after nerve injury, and this is actually a sciatic nerve injury, by placing a loose ligature around the sciatic nerve, makes the animal very hyperalgesic. They can stand very little pressure on their paw. They don't like that at all. And you'll see that now here are these A beta fibres coming back into the more superficial layer. Now, this very same finding, incidentally, has been produced by Dr. White by using the chemotherapeutic agent vincristine, which is, of course, an agent that can produce a neuropathy. Similar findings produced by the drug Taxol, which is another chemotherapeutic agent capable of producing neuropathy. So this is a pattern that occurs in association with neuropathy. And of course, this is a rather malignant condition. I hear people talking about benign pain, cancer pain and benign pain. Ongoing pain is not benign at all. It becomes malignant very quickly. Dr. White has done a very interesting series of studies published just in the last 18 months in the journal Neuroscience, where she's looked at the role of neuropeptide Y and vasoactive intestinal peptide, which are two important peptides in the spinal cord. I don't have time to show you these studies, just to give you a summary. But she found, in fact, that neuropeptide Y and VIP will, in fact, produce, via some cell type in the spinal cord, in the case of neuropeptide Y, release of neurotrophin 3, which then acts on a tyrokinase receptor to actually cause the increase in sprouting. Now, that's rather extraordinary that a very short time after showing this sprouting, we're now starting to hone in on how it occurs. And this is, in fact, now published in Neuroscience, contribution of neurotrophin 3 to the neuropeptide Y-induced increase in neurite outgrowth. Now, she uses the rat dorsal root ganglion cells. Why not use the spinal cord? It seems as though the sprouting in the dorsal horn parallels very nicely sprouting of neurons in the dorsal root ganglion. Much easier to harvest dorsal root ganglion cells and make them grow. So that's exactly the model that she's used. And here we have neurotrophin 3 infused intrathecally. She used a little mini pump. So an Alzet mini pump, which is about the size of an antibiotic capsule, implanted, connected to an intrathecal catheter, much like one of the Synchromed pumps that we implant in human beings. And here she doesn't have any nerve injury. She's just infusing neurotrophin 3. And this is mechanical threshold. How much pressure can the rat bear on the paw before the rat withdraws the paw? And here's the control saline up the top here. And here is after implanting the pump and infusing the neurotrophin 3. You see the threshold goes way down. The animal becomes hyperalgesic. And here is this is from the paper that I just indicated, looking at attenuation by an antiserum. So she's now pumped in via one of these pumps an antiserum to neurotrophin 3 and in essence blocked out the neurotrophin 3. And here are the percentage of cells with neurites. Well, you'll see that if you have to, of course, have supernatant from the spinal cord, because there's a contribution from the spinal cord going on here, you'll see that with the nerve injury this time, you get a massive increase in the number of neurites. So this is what happens with nerve injury. There are much more sprouts occurring. And if you have the neurotrophin 3 infused, it takes it back to the baseline level. So this may not, of course, be the treatment. We may not be infusing antiserum to neurotrophin 3, but it does open up the possibility now of combating not just the pain, but the pathophysiologic process that has generated the pain. And I think this is a very important concept for further approaches to treatment of these patients. But it does, of course, confirm the fact that there's a disease process going on here. Incidentally, if one looks at neuropeptide Y, neuropeptide Y, in fact, doesn't appear to play an important part directly in this sprouting. Because it's not, you don't get an attenuation by neurotrophin 3. And here's the pathology again. You'll see that there's no staining with horseradish peroxidase of the A beta fibers back here in the superficial layer if you just infuse intrathecal saline. But if you infuse neurotrophin 3, now you've got sprouting back into the superficial layer. So quite clearly neurotrophin 3 does play an important part in the sprouting. So I've given you that as an example, and here is a summary of what's going on. Here's neuropeptide Y release, then in turn releasing neurotrophin 3. Neurotrophin 3 probably acting on a tyrosine kinase receptor here. That's not absolutely certain yet. then producing the sprouting back into the superficial layers. So in conclusion, I think we now have very good evidence that ongoing persistent pain should be regarded as being a disease entity in its own right. We now have sufficient knowledge to be able to help a very substantial percentage of patients right across the broad spectrum of acute pain, cancer pain and chronic non-cancer pain. And I think really all that lacks now is a societal attitude to make pain relief a basic human right. Thank you.
Well, I think you can see for yourself why Professor Cousins is regarded as an eminent spokesperson on behalf of patients with pain, whose lucid presentation spans basic science through societal issues.